Welcome to the, yet again, I think the second tenure of web series, IHRS web series. And I'm so happy to welcome you all because the most important reason is we are with the new EC now. And we have Yash as the president, Ullas as the vice president. Both of them are missing at the moment, but I hope they will join us soon. Busy men working there. So Anup is there, Deepak is there from the EC. So we're going to start this session. This is a very interesting session, and thanks to Dr. Sanjay Dikshit for his all contribution towards IHRS web series in designing the grand rounds and the mini symposium. This is the third one we are doing, and the first two have been really successful and very good. So I am so excited to hear about the lead extraction. That is one of the topic which I really like and look forward to, because in India we are not doing it very extensively, but we have some of my colleagues who are doing very good work in lead extractions also. So without wasting much time, I would just hand over to Dr. Sanjay Dikshit to start the proceedings of the mini symposium along with Dr. John Roshan.
Thanks, Vanita. And congratulations to the Indian Heart Rhythm Society, first and foremost, for conducting just a spectacular virtual IHRS. It was just so good to participate, and a lot of pride in seeing such a successful venture. And of course, Ashish gets the lion's share of the credit for organizing that. He was the chief secretary for this conference. And also congratulations for the new leadership. And I'm excited that the leadership of the executive committee has decided to continue this web series, and that's my privilege to really help organize it. And it's a great opportunity for the local membership to interact with international faculty. And with that goal, today I'm especially excited because the international faculty that are participating in this are both my dear colleagues from Penn and just wonderful people and really accomplished clinicians and researchers. And I think everybody will really benefit from what they have to share with us today. So yes, John, Dr. Roshan, and I'm actually obliged that Vanita has accepted my invitation to join us as a chairperson for this because of her expertise on the subject. But we are delighted to bring the two speakers to you. Just very quickly, in terms of the talks, there'll be a series of 3 talks with about 3 to 5 minutes of question answers in between. But then I would encourage the members to please keep sending the questions, because we do anticipate a 15-minute or so panel discussion in which the questions that have not been answered, we'll try to get the faculty to comment on that. So without further ado, let me start with our first speaker, my colleague, Dr. Robert Schaller. He's assistant professor of medicine at the University of Pennsylvania. He is faculty at the hospital of the University of Pennsylvania. He directs our lead extraction program and is also co-director of our research efforts in the EP group. And he's just a really, really accomplished clinician. And as you will see, some of the work that he has pioneered in the field of lead extraction is just coming out through a series of publications. And he's really sort of pioneered the effort, both in terms of innovating lead extraction and then identifying some new indications. And so I'm excited that he's agreed to join us. And Rob, please go ahead and share with us your expertise on this.
Thank you. Thank you, Dr. Dixon, Dr. Roshan, and the Indian Heart Rhythm Society and the organizers for the kind invitation. It's quite an honor for me. So I'm going to share my screen here. Great. So here are my disclosures, speaking honoraria from various companies. So it's hard to discuss where we are now without briefly acknowledging where we've been. So back in the 1960s and early 70s, the only way to remove leads that were infected was by pulling them, and sustained traction was the standard of care, traditionally by pulling on the lead that was attached to the shoulder or taped to a pulley system from the front of the bed or the back of the bed. And this sustained traction would would persist for days in the intensive care unit, and the status of the lead would be monitored through various chest x-rays. And as it would come, the lead would start coming back. The hemodynamics of the patient would be monitored. And hopefully when the weight hit the floor, the lead would come out clean and wouldn't bring with it some myocardial tissue that represented an avulsion injury and potential surgical complication. The 70s brought the various types of snaring and forceps devices in order to pull the leads directly from the heart or the vasculature. But this strategy of just using traction was still quite limited and resulting in a high degree of complications. Interesting to note that the snares that were available in the 60s and the 70s are quite similar to the snares that we use today, showing the lack of progress in this particular portion of the field. So the 80s brought, of course, the telescoping sheaths era and the era of utilizing countertraction. So to stabilize the myocardium where the lead was coming out, so that you can avoid avulsing all of this tissue right here. And utilizing different types of telescoping sheaths, this changed the way that these procedures were performed and became quite a safe procedure. The indications expanded. Utilizing telescoping sheaths for countertraction allows you to avoid situations like this. This lead is still attached to the RV. You can see that the shadow of the heart on fluoroscopy is quite abnormal. And when that lead finally is removed, you see that the shadow changes fluoroscopically, and the heart comes back to its normal position. Of course, this is a big problem, and you don't want to utilize these techniques unless you have to. And the proper way, of course, to remove the leads in contemporary lead extraction is to try to get the tip of the sheath all the way down the SVC and all the way down to the tip. So that the goal of any extraction procedure is to get the tip of the sheath to the tip of the lead. This doesn't always work, but this is in fact the goal. And there are many power tools, so-called power tools, that you can utilize to aid in the lead removal process by disrupting some of the scar tissue on the myocardium and in the vasculature. I think all of them have pros and cons, and I think they all can be used quite safely if utilized in the proper manner. But a lead extraction technical lead extraction talk wouldn't be complete without discussing the use of an outer sheath. Regardless of the powered sheath that we utilize, I think it's incredibly important to utilize an outer sheath, and I'll show you why. Here we're approaching the SVC with our laser sheath, and we're having difficulty making the turn. You can see that I'm pulling quite hard on the lead. The harder you pull, the more you increase the risk of an avulsion injury. Here, a lot of people would start to laze on this lead to try to get through, but I think it's generally unsafe to laze on the SVC. It's also probably unnecessary. So what you do in this situation, or what we would do in this situation, and as our traditional experience, is to utilize the outer sheath in a telescoping manner to get down the SVC mechanically and eventually remove the lead. I think the presence of the laser sheath underneath the outer sheath, and of course the bigger size of the outer sheath, allows you to dissect free even adhesions in the SVC without using power tools. And later on in the discussion, I'll show you exactly why I think that's important. And a manual outer sheath respects tissue planes, so I think it greatly decreases your chances of a vascular injury. One of the ways that we utilize these tools is an indication that has really emerged over the past 10 years and is one of the most common reasons that we're performing lead extraction here at Penn, and that is unilateral venous occlusion. In most patients, we have tried to avoid tunneling of leads under the skin, as well as abandoning leads and moving over to the contralateral side. In these situations, what we'll do is laze over a lead through the occlusion and then use that laser sheath as a vascular conduit to drop wires and then sheaths. very commonly, the lead will come out or will disengage from its myocardial binding sites prior to the laser sheet crossing the occlusion. So it's very common here to have to snare these leads from below. Here we're snaring it with a gooseneck snare, and then we maintain countertraction from below as we laze over the lead in order to cross the occlusion. And is somebody talking or just some noise? Okay. So in this way, we're able to pass the occlusion, eventually remove the snare from the lead, remove the lead from the sheath, and we can use the sheath as a conduit to drop wires. And this is a very common indication for us here at Penn. About 20% of our lead extraction procedures are for unilateral occlusions. We certainly understand that when we're performing these techniques, we are disrupting quite a few adhesions in the vascular system and the myocardium. So traditionally, you get away with this. These things are generally invisible, but we like to image these adhesions and try to think, is there a way to identify adhesions that would change what you're going to do during the procedure, or perhaps change where you think the risk profile, what you think the risk profile of this procedure is. And in that way, we use ultrasound-based imaging during these procedures and before them as well. So we use intracardiac echocardiography really only because we have extensive experience utilizing this during our complex ablations. You'll have to excuse the images. Many of them are the mirror image of what most people have come to expect here at Penn. We use the mirror image for various reasons and for various technical reasons. It's hard to sometimes switch these on the fly. So I appreciate you bearing with me in terms of how the images look. So we started out by looking at baseline ICE images and monitoring for complications such as pericardial effusions or a flail, tricuspid valve leaflets. But you can also see how the leads interact with each other. You can see the helix, and sometimes it helps you to judge if a lead has perforated the army myocardium. We can judge the baseline tricuspid valve regurgitation, and interestingly, dynamic imaging is very, very helpful. Here you can see the lead actually pulling the myocardium off of the pericardium, and more on that later. And we said, if we utilize ICE imaging during all of these procedures in a systematic way, what can we learn? And we did this systematically in 50 patients, and we found a couple of interesting things. The first thing is that thrombi are the rule on leads. If you look hard enough for a thrombus on a lead or a vegetation, it doesn't matter what you call it, you will find it most of the time. And in this series, we found it we found some sort of thrombi on leads in 3/4 of the patients. Generally, they're right behind the tricuspid valve. And very commonly, they're very, very small, clinically irrelevant, but still there. So an eagle eye TEE operator might see something like this and think that a patient has an infection. So it's very important to have some perspective and context in that these are incredibly common to see, and some of them are bigger than others. They can also hide. This is a thrombus that is coating a lead in the SVC. And this becomes important when you're extracting leads, because sometimes you can shear these off and you're left with these large thrombi. ICE is much more powerful at identifying these types of thrombi or vegetation. In the TEE literature, around 18 to 20% of leads are found to have thrombi on them. So 4 times as many are found with ICE imaging. So the gold standard, I think, these days, if you're looking for a thrombus or a vegetation on the lead, I think is ICE. Importantly, we're also able to identify binding sites from the leads onto the vasculature and the myocardium. And they show up as bright linear hyperechoic type of images on ICE. Here you can see a lead that is in the SVC, and the SVC here is quite bright. I'll show you dynamic imaging that shows you that you can't separate the lead from the SVC. So this is an SVC adhesion. You could also see adhesions to the tricuspid valve annulus, to the leaflets, and very commonly to the RV myocardium. And we correlated these with hinge points on fluoroscopy. These are non-physiologic bends in leads that really shouldn't be present when you pull on them. Here's one in the SVC, one in the SVC here, one in the tricuspid valve. And when the lead is densely adhered to the RV myocardium, what you can see are these cannonball type of calcific images on ice. They're bright. They are always adjacent to the leads, and they're usually quite big. Here you can see another one. And when you see this, you know that this lead is densely adhered to the myocardium, and you might need to change what you do. And when you pull on the lead, frequently you can see the myocardium come off of the pericardium, and it can actually mimic a pericardial effusion on imaging such as TEE. So when you see something like this, we typically go right to a mechanical tool. Laser has a very hard time negotiating calcium. So in these situations, we will use a mechanical rotational sheath in order to easily remove the lead in the setting of all of this calcium. When a lead is removed with these types of, quote, cannonballs on them, frequently it leaves this large cast, not to be conflated with anything bad that's going on, or vegetations or infection. This is just a cast, calcium that is left over from where the lead is. And frequently you're also able to see a little bit of myocardial damage that comes with the territory. And hopefully, and much more on this later, hopefully this type of damage has nothing to do with the subvalvular apparatus. And we found that if you do not identify any binding sites, the procedure is generally pretty easy. Most of these leads come out without lasing past the SVC. They typically don't break. There's no complications, and there's no reason to utilize snaring. But if there is binding sites found, then most of these procedures end up being complex, and that's how we defined complexity, is requiring the laser sheath to pass the SVC, leads being removed, having a complication, or hypotension during the procedure, which is consistent with pulling a lead that has for a prolonged period of time that has an attachment to the RV. So identification of binding sites has implications and might change what you do during the procedure. Here's an example of a patient that had two very old ventricular leads from the right side. Both of them are dual coil, challenging procedure, but we do notice that there's no adhesions in the SVC. The leads might be bound to each other, which is a real problem sometimes, but they're not attached to the SVC. They're floating freely, so that's good. Are you going to have an SVC injury here? No, especially not if you don't utilize laser or mechanical tools unnecessarily in the SVC. You can see that they're traversing the tricuspid valve. You can see some inconsequential thrombi in this lead. But look what happens when you look in the RV. Which of these leads would you rather remove? This lead here that's floating freely through the tricuspid valve, or this lead that appears to be plastered to all of this all these intracavitary structures here, some of which are quite bright. So it's not a surprise that most of the Doppler flow of tricuspid regurgitation is tracking the lead that is attached. That's a clue that leads are attached to the valve. You typically have a little bit of flow that's tracking the lead. So it was also no surprise that this was difficult to remove. And what you want to do here, and this will be a common theme, when leads are attached to the myocardium, you want to lase through all of this stuff. You want to utilize power tools in the heart when the adhesions are in the heart. You want to avoid it in the SVC, but you want to utilize it here to avoid avulsion injuries. And once we removed it, you can actually see the track. This is a new lead. You can actually see a track of where that lead was removed. And the myocardial angle is important too. Here we cannot pass this coil because of the angle. And sometimes you can upsize or you can use a telescoping sheath, but sometimes you don't have the opportunity as the lead breaks here. So what do you do in that situation? Why did that happen? Well, you can see that the sheath is approaching the myocardium in an almost perpendicular manner, and this is quite extensively calcified. So it's not a surprise that the sheath won't pass. And if you get too aggressive with the situation, you could have a problem. If you try to remove it from below, much of the force, much of the traction forces is lost due to this angle. So it's very hard to remove a lead successfully without the use of countertraction from below, and that of course failed as well. So how do you improve your angle when you're dealing with something like this? Well, you can utilize the right internal jugular vein, which we did here. We put a large sheath through the vein, and then we snared the lead through the mechanical extraction tool. And you can see that when we approach the lead in this manner, the angle is much better in terms of being coaxial with the lead. So it's no surprise then that we're able to slowly utilize our mechanical rotational sheath and remove the lead. So angle is an important thing to consider, and the right internal jugular vein is an important access site. Here's an example of a patient that had an old lead that didn't need to be removed. It wasn't infected. There's no adhesions to the SVC. I'm no longer worried about SVC laceration. But what happens when you look in this heart? You can see that the lead is attached to many intravascular, intracavitary bits of tissue here. Some of them are part of the subvalvular apparatus, and some of them are just part of the RV. And so you start getting a little bit concerned when you see this. But what really concerned me is as you start turning the ICE catheter, you start seeing a tissue that's attached to the lead that appears to be much more basal than these structures here. And as you move more and more closer to the valve, you start seeing this. This is what really concerns me. What is this? That's a papillary muscle of the RV. It's clearly attached to the RV. You don't know how strongly it's attached to the lead, but it's clearly attached. And look how small this little leaflet looks. Look how vulnerable this papillary muscle looks. And when you pull on the lead gently, you can see that that papillary muscle comes with it. So what are the odds that you're going to be able to pull hard enough to avoid an SVC laceration and not hard enough to do some damage to the subvalvular apparatus? Very, very rare or very unlikely that you'll be able to do this. So this is a situation where we just walked away. It's much better to have an abandoned lead that you can address at a future date than to have an avulsed papillary muscle. If you do need to remove a lead that's attached to a valve, such as this one, which is attached to the valve leaflets, as well as the subvalvular apparatus, one thing to consider is to snare the lead from below. So in this situation, we can't pull hard enough to track the sheath down the SVC. You want to avoid pulling hard. So what we do in this situation is we snare the lead from below. We wrap it, in this particular situation, we wrap the decapolar catheter around the lead and then snare the decapolar catheter. And then we're able to utilize countertraction from below, which buffered all of the traction forces from above, which allowed us to get the sheath all the way down. Then you can remove the snare, laze through all of those adhesions, and save the valve. But sometimes it's not so simple. These valvular adhesions can be hidden. This is a 15-year-old lead in a young patient. I'm not terribly worried about SVC injury as there's no second coil. And doesn't appear that there's any attachments here in the tricuspid valve. Here you can see a very common thrombi that's likely irrelevant. Doesn't look like there's any attachments here. Is it attached to the SVC? Maybe a little bit, but it's certainly not embedded in the wall. Nothing that would require lasing, nothing that increases the risk of the procedure. But as we start removing the lead from above, we continue to look at ICE. And what you can see now is a little bit of tissue emerges. The septal leaflet of the tricuspid valve is very hard to image at baseline. But if there's an attachment to it, it starts to emerge with a little bit of traction. When you see this tissue emerging, that is a vulnerable valve. You do not want to pull any harder you want to keep this bit of tissue right here. If you pull any harder and that tissue goes too superior past the valve, you're jeopardizing that leaflet because these things are complex. And if you grab enough of these little cords that may or may not be responsible for maintaining the integrity of the valve leaflet, then you can have an injury. So you want to do is laze through all of these adhesions. Here's the laser going right through all of these adhesions to the tricuspid valve. And you could see that there's no damage after you utilize power here. But you can see exactly where the lead went through. It's almost as if the lead went right through this area right here. And this is what you want to see. You want to see these casts left here, because if you look at color Doppler, there's no color flow through here, just the central jet that was present throughout. So utilizing laser through these adhesions is incredibly important. This is a dramatic example of a patient that had leads in for only a year and a half. He needed them to be removed because of persistent swelling in his left arm. The right atrial lead came out with simple traction, but the right ventricular lead was much harder to remove. We said, why would it be so hard to remove after a year and a half? Should we just pull a little bit harder? But you can see that if you start looking at what this is attached to, and you take a closer look, you can see this. This is the tip of the lead attached to the RV, and it's going right through. It's not through, but it's attached to this as a papillary muscle. And look at the connection between the papillary muscle and the RV myocardium. There's just a wisp of tissue, 1 or 2 pounds of traction force, and you will pluck this right off. And this is worse than a flail leaflet. This is an entire leaflet that's flail, and the papillary muscle will be traversing the tricuspid valve. This will be a huge problem for the patient. This patient had no tricuspid regurgitation. So what do? It's hard to abort a procedure, but that's what we did. We sent him to surgery, and this is what the surgeon found. The lead attached to the papillary muscle, and even in the surgeon's hands, who tried to pull the lead away from the papillary muscle, even directly with his hands, it still broke off because it was adhered so densely to that papillary muscle, and the patient was left with a little bit of lead in the RV. It's irrelevant, but the most important thing is that the patient's tricuspid valve is now fine, and the patient is doing well with epicardial leads. And ICE can be helpful in various different ways, not only looking for adhesions. Here is a case of an 80-year-old woman who had very old leads. You can see these leads are old, they're over 20 years, and she had just a horrible staph bacteremia with abscesses and vegetations. This lead, this is the youngest of the leads, and despite getting the laser sheath all the way down, it would not come out. Why is that? This outer sheath is all the way down to the tip, but it simply wouldn't come out. And the reason is there's a huge cannonball right here. This is a dense calcific adhesion to the myocardium. Laser is not very effective in these situations. So what you do here is you grab a mechanical rotational tool, and no problem, it comes right out. But then we try to remove the right atrial lead, and we have problems. The lead comes apart. So what do you do in this situation? If it was a non-infected case, who cares? You have a little bit of lead in the right atrium, not that big of a deal. Is this a risk for ongoing infection? Well, you don't know. It's invisible fluoroscopically. Insulation is, I should say. So how much insulation is left, and do you need to remove it? So you look at ICE, and you can see that there's a very long segment of insulation that's traversing the right atrium all the way down to the tricuspid valve. This certainly needs to be removed in the setting of vegetations all throughout these leads. But it's hard to snare something that's invisible on fluoroscopy. You know where the tip is, but you don't know how to get around that insulation. So you can utilize ICE to find the insulation and to try to get the gooseneck snare around there. And now you can see that we're utilizing only ICE imaging. We're able to encircle that insulation and then close it. Here you can see all the thrombi and vegetations on this lead. But as we start pulling, even with countertraction with our sheath, this insulation starts stretching, and eventually it pops right off. So have we removed enough insulation in the setting of infection? Well, you don't know. To look back at ICE, and you can see there's still a very long segment of insulation. We simply were not able to get the gooseneck snare distal enough to the tip in order for it to be removed. So we utilize something that we've been doing more and more, which is called the snare over the snare technique, where this is the distal gooseneck snare through a very long sheath. We're able to snare the insulation like we were before, and then by pulling down on that snare, we're able to rail a second snare over the first snare and hopefully get more distal. And this is the way it looks. This is the first snare that snared the proximal portion of the insulation. The second snare then enters the same large sheath, and we're able to rail that second snare up while holding traction on the first snare. And this will allow us to get much more distal and give us a chance to remove this completely. And even with this type of a strategy, the insulation still started to stretch, but we got lucky and eventually it popped off. So how much insulation was there on this lead? This much insulation, certainly more than enough to maintain bacteremia in this woman. So very effective technique. Even with all of these different techniques, we have no illusions that there still is risk of vascular injury. We utilize the bridge occlusion balloon as most people do around the world. We think this is likely the standard of care, at least to have a wire up to the right IJ in order to utilize this compliant balloon to tamponade a potential injury here by blowing it up and giving the surgeon more time to rescue the patient. I think it's much more important to utilize this balloon in this situation where the lead is bound to the SVC. Here we're pulling on the lead, and as you can see, it doesn't separate from the SVC, it stretches the scar tissue between the lead and the SVC. This is a lead that is really bound, usually in the setting of having an SVC coil. So it's very important to have a balloon available in this situation, as opposed to a lead that's just freely floating. There's really no risk of SVC injury here as long as you utilize your tools correctly and avoid lasing in these situations. And here's a lead that is mildly adhered to the SVC. You can see we're pulling on the lead. It's pulling a little bit of SVC with it. Certainly nothing that's going to cause a problem. It might come off with a little bit of traction or utilizing an outer sheath. You shouldn't need to lase in this situation, but there's a continuum of adhesions of leads to the SVC, making the bridge more appealing in these situations. However, we'd rather avoid being reactionary and try to avoid these situations rather than needing to use these tools. So this is the technique that we use in situations where we think that the lead is attached to the SVC. If you pull the lead from above in a typical situation, what happens to the lead is that it pulls upward and to the right of the screen, slightly away from the SVC. But it doesn't separate very much. And if the lead is adhered to the SVC, it kind of pulls the SVC with it, or at least that's what we think is happening. So what we do in this situation is we snare the lead from below, either with a needle's eye snare or a deflectable catheter with the gooseneck snare, as I showed you before, and we utilize simultaneous countertraction. And this is what happens. This is what the lead looks like when it's pulled from above. And if you add simultaneous countertraction, this is what happens. The lead becomes much more parallel with the SVC. It pulls away from the SVC and you enhance the rail strength of the actual lead. And when you do this, you can measure what the lead looks like in terms of fluoroscopic imaging, as well as ICE imaging. And then we have an animation of what we think is happening. So this is what it looks like at baseline. When you pull from above, the lead comes slightly off of the SVC and it separates a little bit from the SVC, but not a lot. But if you have a focal adhesion here, I think that you can potentially create this lip. And particularly if you use an oversized sheath, you can envelop this portion of SVC into the sheath. And if that happens, you can potentially unzip the entire SVC. And this is what SVC injuries, how they are described, long linear lacerations. If you pull from below at the same time, you equilibrate some of these forces from below. You pull the lead to the right, as evidenced fluoroscopically. You separate the lead, as evidenced by ICE imaging, and everything becomes more parallel and you enhance rail strength. So this, I think, makes it safer if you need to utilize lasing or power tools on the SVC. I think simultaneous traction from below makes the situation safer. And this is what it looks like when a sheath is in place. When you pull from above, look how little that lead comes off. That's because you have a stiff sheath that's stopping the lead from being pulled over. And you still are somewhat perpendicular to the SVC. And if you look locally, you can see that the sheath is actually scraping the lateral wall of the SVC, which is on the bottom here of the device. If you utilize simultaneous traction, look what happens. The lead pulls off of the SVC and it becomes much more parallel. And if you look locally, now you have a millimeter or two between the sheath and the lateral wall, which is so important and maybe all that's needed to avoid an injury. And this is what we think is happening. This is a vulnerable SVC here, especially if you're utilizing an outer sheath with simultaneous traction. You maintain a much more coaxial parallel orientation, giving you a few millimeters that you might need to avoid an injury. So we utilize this technique if we think that the procedure is high risk, if there's an SVC coil, if there is an old lead, if there's a young patient, or if ICE imaging shows that the coil is in fact adhere to the SVC. This is very similar to another technique that we used after the extraction, which we have termed the body flossing technique. After extraction, or sometimes even in situations where you haven't extracted a lead, sometimes you can get a wire through the vasculature, but you cannot place a sheath. So what we do in this situation, which again comes down to enhanced rail strength, is we'll snare the wire from below, sometimes on the fly when we're not expecting to. And utilizing simultaneous countertraction, you're able now to drive the sheath right through the innominate vein. It's the same exact concept of enhanced rail strength. Despite utilizing these techniques, we don't avoid the problem with all of these thrombi that are sometimes present on the leads. Here you can see a sheath traversing the SVC and actually pushing on a big thrombus that is on the sheath and pushing it downstream. So it's not uncommon after our extraction procedure to see things like this. This is a bit of a dramatic example, but it's not terribly uncommon. In about 5% of patients, you will see thrombi that are quite large and can be quite scary, and you're not exactly sure what to do. So even if it's a non-infected thrombi, you can usually get away with anticoagulation in these patients. But if it's an infected thrombi, if it's a vegetation, what do you do in this situation? Do you try to remove it? Do you try to remove these thrombi before the extraction procedure? 20% of these patients are still dying at 1 year. So we've been utilizing this aspiration tool, and there's various ones on the market, but this is the only one that I know of that's able to avoid vein-to-vein bypass and able to direct the sheath to where you want to go. And this is the 8 French penumbra system. The problem with it's nice that you can utilize this through a deflectable sheath. You can get where you want to go, but it's only 8 French, so it's limited in terms of how much of this thrombus you can remove. It comes with this little tool that you can move back and forth to try to disrupt some of this thrombus. And we actually try to get some of this thrombus after these types of procedures, but you can see that it gets sucked up into the mouth of the penumbra, and sometimes it gets stuck. But if you're patient, sometimes you can start to remove much of this thrombus, and by utilizing this little poking tool here, much of it can be removed. Some of it, of course, is going to eventually embolize to the lung, but much of it actually can be removed. And we think this might be important for situations where there is infection. We're utilizing this to see how effective it is. Newer versions are coming out that are bigger. The next iteration will be 12 French. And we think there might be a role for aspiration either before a procedure in the setting of an infected case or after the procedure in infected cases, as well as non-infected cases where you end up with all of this thrombus. Speaking of thrombus, the bridge, we have noticed in our experience utilizing the bridge balloon that this is a thrombogenic type of tool. You're utilizing these procedures in patients who are not anticoagulated, and you can see that this balloon expands when it's inside of the bloodstream. So it's no surprise that this can become a little bit thrombogenic. So what a lot of people do is keep this bridge balloon in the IVC during their procedure. That way, if they need to utilize it, they quickly rail it up. I think that might be a mistake, or at least I think there's a way to utilizing it smarter. After our procedures, we have imaged this balloon with ice, and we've noticed that there are sometimes very large thrombi that are coming off of the balloon and are in the SVC. Sometimes they're incredibly impressive and sometimes they're small, but more than 60% of the time in these situations, we have noticed large thrombi as defined as thrombi that are greater than 1 centimeter. And these are quite scary. So we just finished a study where we utilized the balloon in two separate strategies. The standard cohort, where we put the balloon in the IVC at the beginning of the case. That is right when you establish femoral access, you park the balloon in the IVC, and you move around to the patient's other side and perform the procedure. You open the pocket, you prep the leads, and you remove the leads. And then sometimes you reimplant. At the end of that procedure, we image the balloon, and then we remove it from the body. In the abbreviated cohort, what we did was we put the balloon up only right before we were about to lase. So we put up everything that we needed femorally, we prepared our leads, we prepared our laser, we called our surgeon, and then we moved down to the groin and we put the balloon up. And then we removed it right after the lead was removed and hemodynamic stability was confirmed. So obviously the abbreviated cohort would have a balloon dwell time that was much shorter than the standard cohort. And what we found was that was in fact the case. It was a much shorter dwell time, and the amount of thrombi we saw in the standard cohort was 14 out of 21 cases, and the amount of thrombi that we saw in the abbreviated cohort was 1 out of 21 cases. Unfortunately, one patient came back in this cohort with a symptomatic pulmonary PE, pulmonary embolism, possibly related to the thrombi. It was one of the patients that had a thrombi, but of course we do know that all these procedures, one of the recognized complications is a pulmonary embolism, but it did in fact happen in this cohort. So these data are not published yet. These are under review, but we think it is probably better to utilize the abbreviated cohort during these procedures. And that sometimes requires you to scrub a couple of times after you go down to the pocket, after you go down to the, from the femoral region back to the pocket. But the amount of thrombi that we've seen and the size of the thrombi, I think is relatively scary. We're working with Philips to try to figure out other strategies to maybe make the risk of thrombi lower and decide so one of the compelling reasons that to keep the balloon up in the beginning is to size it, to actually inflate it in the SVC, to know how high you're going to need to push the balloon in order to be in the right spot, as well as to see how many cc's of fluid you're going to need to fill it. So whether you do that and then remove the lead, remove the balloon all the way from the sheath, or whether you keep it in the IVC and just do it right before you're about to lase, we're not sure yet, but I think keeping in the IVC throughout the entire procedure is probably not a great idea. So more on this to come. And the last thing I want to talk about, I know that we'll be hearing a little bit more about the unique extraction experience in the setting of infection, is how we manage our pockets after infection. This is what we used to do. Frequently, we will debride the entire pocket and cut out quite a bit of tissue after the lead has been removed in the setting of a pocket infection. We used to utilize a drain of some sort, usually a JP drain or a Blake drain, that exited the side or the bottom of the pocket in order to drain some of the tissue that inevitably builds up in an infected pocket. But we don't really do that anymore. And the reason is we use this tool called the Aquamanus, which is made by Medtronic. This is a heavy duty coag device. It really is bipolar irrigated RF. You can see from one pole to the next. And technically it's called a bipolar sealer. So it's actually supposed to work on a cellular level to seal up some of these cells and avoid the oozing that sometimes occurs when the pocket is infected. And the way that we utilize this tool is this is our typical strategy with an infected pocket. We utilize a elliptical incision around the necrotic area. We perform a complete capsulectomy here. And here you can see the underlying tissue that is frequently abnormal and oozes and bleeds thereafter. So what we do is we utilize the Aquamanus throughout the entire pocket here. Here, you see how strong it is. One application just chars this area. And 5 minutes later, you need to remove some of this fluid here so that you can deliver some of this current. And 5 minutes later, what you have is a pocket that is completely dry. We now avoid using drains that I think actually provokes some of this fluid buildup, is uncomfortable, and leads to prolonged hospital stays. We just close the pocket primarily here. And we have gone from utilizing drains in 100% of patients to utilizing drains in 50% of patients to utilizing them in none of the patients now. And frequently these patients are actually able to leave a day or two after these procedures, if appropriate from an infection standpoint. So in summary, I think that lead extraction is unique in that it lends itself to innovation. I think rail strength is crucially important to avoid vascular injuries. I have been incredibly impressed by how imaging has helped us. More tools are set to come sooner. 3D ICE, and of course there's an opportunity for imaging with TE, which really hasn't been defined. Different extraction tools are certainly coming very soon. And I don't think that I have all the answers. I think there are many solutions to the same problem, which is why I love hearing others' tips and tricks as well. So with that, I will end, and thank you very much.
Rob, that was a terrific presentation, and I'm sure everybody in the audience appreciates your thoughtfulness in pursuing these things, and of course your talent in accomplishing some of these really challenging extractions. So that was really great. I know that we are running a few minutes behind, and we have two other speakers. So if it's okay with you, Rob, what I was going to propose is there are a few questions that I definitely think the audience are very interested in hearing your opinion. So why don't we save the questions for the panel discussion where we can, really get you to weigh in. So, so with that, thank you for this wonderful talk. And I'm now going to move on to our next speaker, my colleague, Dr. Andy Epstein, who is a professor of medicine at Penn and the chief of cardiology at the Philadelphia VA Medical Center. Andy obviously needs no introduction, but just to kind of reiterate the generational experience that he brings to this symposium today. I mean, he's been involved with devices for an extended period. He his career at the University of Alabama, where he participated and actually was the chief recruiter for a series of NIH-sponsored multi-center studies, such as the CAST trial, the AVID trial, the AFFIRM study. And of course, he's been the chairperson for the writing committee for guidelines for device management and indications. And so it's really a pleasure to kind of have Andy talk to us and share with us his extensive experience in what can we really do to reduce the risk of infections. Obviously, talented people like Rob are always there to bail us out, but what can be done to avoid infections in these implantable devices? So Andy, please share with us your experience on this subject.
Thank you very much, Sanjay, and thank you for the IHRS for inviting us. My talk is going to be much lower technology than Rob's, but I think everyone will agree that it's better to avoid infection than having to deal with it. I'm going to approach this talk from the point of view of discussing four things: the epidemiology and the magnitude of the problem of cardiac implantable device infections or CIED infections. How do we make the diagnosis and how are these infections classified? I'm going to talk a little bit about antibiotics and treatment, but focus at the end on prevention. This slide shows the problem of infection that has been increasing in this country at least. In the upper left frame, you can see that in red, the overall device infection rate has been increasing markedly over the last couple of decades. And while the pacemaker infection rate here in green has gone up a bit, the infection rate is really most marked for more complex devices, including defibrillators and CRT devices. Here on the upper right is a depiction of the problem in terms of the complexity of devices. You can see here that whereas bloodstream infection has been sort of flat, the pocket infection overall has been increasing. And this is most important for complex devices, CRT devices versus defibrillators or simple pacemakers. And the problem is not just one of numbers, it's also a problem of mortality. The bottom frame here shows very well that if there is a device system infection, the mortality is markedly increased, and this is especially true again for the complex devices. The black shows that the mortality rate when there is no infection is low, but the yearly mortality rate when infection has been present of a CIED system is large. So why do pocket infections occur? Well, the most evident reason is that contamination occurs at the time of implantation due to improper handling or inadequate sterile technique. Postoperatively, there can be surgical site infection, and there can also be hematologic spread of bacteremia from a secondary source, and certainly if a device erodes, it has to be considered to be infected. While most infections occur within a year of implantation, a small but significant amount occur after 1 year. Importantly, there's often asymptomatic colonization that is in pockets that lasts for a long time. And in fact, very nice work using sonicated tissue at the time of generator changes finds bacteria not infrequently. There are a number of risk factors for infection that we need to know about. One is end-stage renal disease, and especially when a dialysis catheter or the AV fistula are present. A history of previous device infection by itself is a huge risk, conferring a 7 to 8-fold increase. Corticosteroid use, simple kidney disease, malignancy, COPD, diabetes, and heart failure are all risks. And within the procedure, the development of a hematoma is a huge problem, and we do everything that we can to avoid hematomas, because especially if a pocket has to be reopened for a hematoma or lead dislodgement, the risk is very high early on. Less experienced operators, the presence of a temporary pacing catheter, device revision or upgrade, and generator change are all risk factors. I'm going to emphasize this problem of reopening pockets again and again. And this slide shows this very nice from Marty Borlef's a number of years ago, that each time the pocket of a CIED is opened, there's actually an exponential increase of the risk of infection. By the time you get to the 4th opening, which is not uncommon, and when younger people get devices, you're approaching a 10% risk of a complication. The REPLACE trial was done in the US and Canada, I believe, in the 2000s. And in this study, there were 2 cohorts. So one was a simple generator change, and the cohort 2 was a group where there was not only a generator change, but also a planned addition of a lead or a system upgrade. And using as a reference a simple generator change here with no lead being added, the complication rate is on the order of 5%. However, when you're upgrading from a single or to a dual chamber pacemaker or defibrillator, the risk is higher. But when you're adding an LV lead, the complication rate actually goes up to 17%. So not only is opening a pocket a problem, but the complexity of what you do in the pocket also confers a risk. So how do we make the diagnosis of infection? These are all pictures of nicely healed pockets. There's no erythema, no swelling. Patient doesn't complain of tenderness. And we are very happy when we see pockets like this. A big risk, though, is in the series of slides that Dr. Wilkoff was kind enough to share. And this is a puckering that's at a pocket. And this at first glance looks okay, but as Dr. Schaller will attest to, when there's puckering, you have to suspect that there's a smoldering infection going on deep inside. And in fact, when this patient is followed over a year, you can see that the puckering becomes a little bit more generalized. There may be a sense of purulence being just beneath the skin in the middle. The skin begins to break down, pus extrudes, and then finally there is evulsion of the device. A number of classification systems have been used for infection. At one end of the spectrum is localized erythema, which is present in the first 7 days after an operation. And this is not treated as an infection. Certainly, if there's a cellulitis that does not infiltrate the pocket, we treat with antibiotics and monitor. In the middle of the group of classification is superficial cellulitis that doesn't involve the deep pocket itself, and this must be distinguished from postoperative inflammation because these people we treat with antibiotics. Importantly, there are no systemic signs, but this kind of infection, this intermediate pocket problem, can progress to complicated infection, which is characterized by valvular involvement, endocarditis with positive blood cultures. And we have to remember that a negative echo does not necessarily exclude system infection. I'm not going to say very much about extraction because Dr. Schaller has covered that in detail, except to point out that the recommendations from the American Heart Association are that complete device and lead removal is recommended for all patients with definite infection, as evidenced by valvular and/or lead endocarditis. This also goes for pocket infections, and most notably, for people with occult staphylococcal bacteremia. This should be attributed to a CIED infection if one is present and system extraction is warranted. Now, why is it, I'm sorry, before I go on to one other comment about extraction, I want to say that the extraction and the use of antibiotics are not mutually exclusive. This is also from the AHA paper, in that if there are blood cultures that are present, based on the presence or absence of vegetations, antibiotic continuation after device removal is usually 4 to 6 weeks. On the other hand, if there is a negative TEE and no evidence of lead or valvular infection, antibiotic use can be somewhat truncated. And then finally, if there are negative blood cultures, whether or not it's a lead or pocket infection, antibiotic treatment is usually for 10 to 14 days. Just to make the point about the importance of extraction when systems are infected, the relapse rate without complete system removal is exorbitant. This is a number of studies that have looked at the problem, and basically, if you don't get out all the hardware, when either the leads or the pocket are infected, the recurrence rate and the ongoing infection rate ranges from 50 to 100%. So infected device and system means extraction and antibiotics. So finally, let's talk about what we can do to prevent system infection. This is I think, a lovely paper that comes from Dr. Chen and colleagues in Taiwan. I first learned of this paper when I was at a meeting there, and he showed these data in the preliminary form. They developed what they called a bundled preparation, in which, in addition to standard skin preparation pre-procedure with chlorhexidine and alcohol, the night before, these investigators used an alcohol scrub of the skin. 10 minutes before beginning the procedure, they used a providone iodine scrub, and then the standard skin scrub in the operating room. At the time when they converted from a standard skin preparation to a bundled preparation, the overall infection rate plummeted. And most importantly, the complicated infection rate versus the uncomplicated infection rate went virtually to zero within a year. This is a slide from Dr. Chen's presentation in which he showed that the night before they used this large sterile gauze covered with alcohol to cleanse the skin. 10 minutes before, there is a first scrub with povidone iodine, and then in the operating room as the standard procedure is used. So I think the point here is that skin preparation the night before is extremely important. Our staff here at the University of Pennsylvania tries, and at the VA tries to get people a scrub of some kind the night before they come in for a procedure. In terms of using perioperative antibiotics, an antibiotic has been shown to perioperatively to decrease the risk for infection. One that it has anti-staph coverage should be administered. For people who are allergic to penicillin, either a cephalosporin is used within 1 hour before the incision, or if vancomycin is used, this should be given 2 hours before the incision because tissue penetration is much less with that drug. Intraoperative, we also do use antibiotics. In fact, there are no standards, and in some studies have shown that simple saline flushes are as effective as antibiotic flushes, but most of us do use antibiotics, and if an antibiotic flush is used, cefalozin is recommended, or vanco for penicillin allergic patients, but not the typically and traditionally used skin antibiotics such as neomycin, polymyxin, and polysporin, because these drugs have a high rate of topical reactions that can mimic infection. So we try to use a cephalosporin if possible, and using the same agent that is given perioperatively IV decreases the risk of local reactions. New kids on the block that we have available to decrease the risk of infection are the absorbable antibiotic envelope. These are multifilament knitted mesh envelopes with glycoprene filaments that are laced with rifampin and minocycline antibiotic. These meshes are resorbed in about 9 weeks. They are very effective to decrease the risk for infection, especially with generator changes and reopening the pocket. These devices also hold the generator in place. The RAPID trial was a randomized controlled trial published in the New England Journal last year, comparing use of the envelope to not using the envelope. There was a statistically significant decrease in an already low rate of infection in these patients. And in fact, this benefit extends to 3 years. And then finally, should we use antibiotics following the procedure? The PETA trial administered in Canada with Andrew Cron as the PI showed that adding an incremental antibiotic post-procedure in addition to pre and peri-procedure antibiotics did not statistically decrease the risk of infection at 1 year. Now, certainly the data are consistent that post-operative antibiotics do not decrease the risk of infection, but there's some patients for whom a more prolonged antibiotic use can be justified. For example, those with long hospitalizations where you would anticipate a lot of skin bacteria, those with violated skin, providing tracts for bacterial seeding, for example, with chest tubes. And if antibiotics are prescribed, they should be limited to 24 hours. If a cephalosporin is used, a single dose 4 to 6 hours after the procedure is all that is needed. If vanco is used preoperatively, it remains for hours, and there is not a need for repeated dosing. Prescribing several days of antibiotics is not advised. And one thing that I've always done is to discontinue the IV on the side of the operation to decrease the risk for bacterial introduction via that portal. So as my last slide, and to conclude, system infection is a growing problem. Infection requires complete system removal. Attempts to salvage pockets almost always fail. And infection risk can be mitigated by careful perioperative care, including skin preparation and antibiotic treatment. Thank you very much.
That was terrific, Andy. I'm going to now ask my co-chair, Dr. Roshan, to take over the rest of the session, please. Thanks.
Yeah, thank you, Dr. Dikshit, for the very nice introduction and taking the meeting so far. It now gives me pleasure to welcome Dr. JP, who is very well known to this audience and who heads the EP program at Jayadeva, which is one of the pioneering national institutes of high volume. And as we all know, lead extraction is a niche area in the country, being done by a couple of academic institutions and in large volume, as well as some of the corporate centers across the country. And I now welcome Dr. JP to share his experience with us on lead extraction.
You have to unmute yourself, Dr. JP. Kindly unmute yourself, Dr. JP. Dr. JP, please unmute yourself. Dr. JP, you have to unmute yourself.
You may have to stop sharing and unmute and then start sharing again, Dr. JP.
That's an idea, yeah. Okay.
Now you can start sharing.
Ah.
Perfect.
Can you hear me now?
Yes, yes, very clear.
Okay.
Perfect.
At the outset, I would like to thank the IHRS and Dr. Sanjay Dikshit for having invited me to give this small talk on a very limited experience of doing lead extraction in India. Now, first of all, before I start this talk, what you have to realize is in India, lead extraction is not covered by any insurance. So it is an out-of-pocket spending by the patient, and the approximate cost for a two leads and lead extraction comes to approximately about 500,000 rupees, which would boil down to about $6,500 to $7,000 US dollars. So with this in mind, and I can't use too much of hardware because of the financial restraints that we have in India. Now, having said that, I'll share with you some of the experience that I've had in doing lead extraction over the course of the last few years. Now, I'll start off with a small case history, see how it goes. Now, this is a 54-year-old male. He had a dual chamber ICD implanted in 2013 on the left side for primary prevention. And in 2015, he had an infection and the device was relocated subpectorally by the surgeon in 2015. In early 2016, the device was explanted, and this is what they do, which is very common in India, that is they cut the leads. And that's where the cut leads are poking out there, as you can see on the upper part of the panel on the left side. And they reimplanted the lead on the device from the right side. And in mid-2016, he noticed bogginess of the pockets and started developing fever and chills of 3 months duration. He underwent multiple hospital admissions, and by the time he had spent about 16 lakh rupees, that is almost 1.6 million rupees, which is equivalent to about $22,000 US dollars. By this time, he was absolutely broke, and he was sent to me because I'm in a government institute. Now, this man said, I want the device out, and he was having chills and rigors every day. He had lost weight, as you can see. He was a big man. And this is the boggy pocket on the right side, and this is the sinus from which the pus was pouring out on regular basis. And this is what had been done, to add insult to injury. They had pulled the lead out, they had cut the lead on the left side, they had pulled the lead partially on the right side, and he had this whole messy thing going on there. And a TE showed, transesophageal echocardiography showed a large vegetation which was sort of there in the right side of the heart. Now, I was left with the choice of what to do because this man had no money. And each of this, and this for lead locking stylets and the rotational sheaths, it would have cost him at least 10 lakh rupees. So I did what was best for this patient, keeping his finances in mind. So I sent him for a cardiac surgical extraction. That's a surgical extraction. The surgeon removed the whole thing. And this is the sort of, vegetation which was stuck onto the lead. Now, this is one of the scenarios, and this is not too uncommon in what I see over the course of time. Now, before I go further, as Dr. Epstein said, there are different ways of classifying infection. Here, I have taken the ESC guidelines for classifying infection, which can be classified as superficial incisional infection, which is just a local infection and involves only this local and subcutaneous tissue. And if this happens, we just give them antibiotics, and most of the time this resolves. However, if there is an isolated pocket infection, and even if it is local, the local inflammation is at the generator pocket, or it courses along the lead, and then we need to get this out. It could also be isolated pocket erosion, or there could be just bacteremia. There could be pocket infection with bacteremia along with the local signs of infection. There's a positive blood culture. There could be CIED related endocarditis without pocket infection, where you may not find anything in the pocket, but you will have endocarditis going on, and you will get a positive blood culture. The pocket infection with lead or valvular endocarditis is also not too uncommon. And occult bacteremia with probable CIED infection, we don't see it that often. Probably we are missing a lot of this. Now, having said this, these are the things that I get. Some of them come like this. These are boggy, pockets. There is a relocated device here, and then you have this erosion. And this is a lady who was walking around with this for 4 years because she did not have money to get this out. So this was a CRTD that was poking out, and she used to just pack it up inside and move around until she started developing, febrile illness, and she was having chills and rigors all along. Now, I'll show you some of the demographics that we have. I'm only showing you the last 3 or 4 years. The number is not too big. It's about 126 patients, and these are 82% of all my lead extractions. So most of the lead extractions, unlike in the West, are for infections. In the West, most of the data shows it's about 55 to 60% are infected patients, but in India, probably it's much closer to 80 to 85%. The age is about 53 plus minus 20 years. It's much younger than the Western group of patients. There's a male preponderance, and you can see there's usually in our patients, there is a long duration of symptoms. They would have gone for multiple hospital admissions. You can see the number of previous hospital admissions of at least about three to 5 times. And they would have had an out-of-pocket expenditure of almost $5,000 plus minus $3,000 before they land up with me. And this is my data, which I have collected from our patients, and they would have received a number of courses of antibiotics before they come into the hospital. They would also have had a number of procedures to relocate the device, put the device under subpectoral pocket, and many a times when this has failed, the leads would have been cut and put on the other side. The type of infection is usually the most common would be the isolated pocket infection without bacteremia. And some of this, the bacteremia is not there because of multiple courses of antibiotics which these patients would have received. Then there is a pocket site infection with bacteremia, which is not as big as the isolated erosion because we get erosions very commonly, and all patients with erosion usually have infection, as we all know. The CIED lead endocarditis is about 7%, not too much. So by the time they would have received many courses of antibiotics when they come over to my center at least. Now the device detail is as the mean dwell time has been about 10.6 years. It has ranged anywhere from 4 to 30 years. The oldest leads that I have removed have been 30 years old. I have extracted approximately about 233 leads. These are the various device types: single chamber, pacemaker, 26, The most common would be the dual chamber pacemakers, followed by the single chamber ICDs. And if you look at the type of leads, the passive fixation leads are more common, both in ICD as well as the pacemaker leads, because many of the leads, many of the pacemakers and devices are implanted by the interventional cardiologists who rather prefer dual coil, passive fixation lead in many of the patients. And we have had about 25 coronary sinus leads which we have removed. I have not had the luck to remove any star fix leads because we have not had that many star fix leads implanted in India, but most of the leads have been the passive leads which are usually used. These are the details of the extraction. I have not included any patients who have had just lead explants. Explants are, as we know, we just put the stylets which we use for implants, and then we are able to pull it out. And all these are extractions where we have used specific tools to remove it. The lead locking stylets have been the most common, but the most common have been the mechanical rotating sheaths which I have used. We have been using laser sheaths only since the late 2016 when we got a laser. Actually, the laser came in as a part of a coronary laser program where they wanted to do a coronary laser, and I used that opportunity of using this laser console to do the lead extractions, and we have done about 23. The problem with lasers in India is we have the lasers require some amount of maintenance, and we are unable to get the xenon gas and the maintenance very well. So it is down for quite a long periods of time in between. So we have to resort back to the mechanical rotating sheaths more often. I have used additional, femoral approach, which has been described by Dr. Schaller very elegantly in about 5.2% of the cases. In about 3% of the cases, we have used the hybrid procedure where I have tried to, extract the leads completely, but would have been unsuccessful. And since these are infected cases, we always try to remove all parts of the, device completely. So I'm rather aggressive even in sending them to the OR. To get it removed, and have opted for a surgical removal as a primary procedure in about 1.7% of the cases because of various reasons, either because of financial constraints or because of large vegetations. The procedure times have been about 90 plus minus 67 minutes with a fluoroscopy time of 27 plus minus 17 minutes. So we have had complete success because I have been sending some of the patients to surgical removal because we can't leave any piece of this lead or any part of the system in the body in case of infection. So we have tried to get everything out. I've had complications, of course. Minor bleeding has been the most common with the pocket-sized wounds, but this did not require blood transfusions. We have had minor pericardial effusions which did not require tapping. Groin hematoma has been there because we use large sheets in the groin, to keep the wire. We do not deploy, in India, we do not deploy the, balloon because first of all, it's very difficult to get the occlusion balloon and it is not commonly used. So we keep it as a standby on the table. We just keep the wire in place in the superior vena cava when we go and start doing the procedure. I've had one major bleeding where it was bleeding completely from the, this site where when I took out the sheath, that was in my initial days. When I took out the sheaths, I did not have a purse string suture around it and it started bleeding profusely. I had to call the surgeon and we had to give multiple blood transfusions. One of my first laser cases, I had a perforation of the right atrial appendage, and this was a live case which I was doing, and the patient actually collapsed with a pericardial effusion. However, the surgeon was there and we were able to sort of salvage these patients immediately. We have had about 2 patients who died in the first 30 days. These patients had intractable sepsis and they had hypotension with multiple organ failures, and we could not save the patient because of this infection. The long-term mortality, whatever I had, we have followed up for approximately for about a year, and we have lost follow-up approximately about 20 to 30% of the patients. But whatever follow-up we have got, we have had about 2.4% mortality, which is much less. Actually, you can have a mortality in infected patients up to 20%. The mean duration of stay in the hospital in the ICU is about 8.3 plus minus 7.1 days, meaning that these patients require a number of days in the intensive care unit where we prefer not to send them to the wards. The duration of hospital stay, as you can see, has been quite long, nearly a month. So all these add to the cost of the procedure in India. The most common organism which we have isolated, because we take not only blood cultures, we take cultures from the pocket, we send the pieces of removed tissue as well as the leads for culture. The most common organism has been the coagulase negative staphylococcus. We have had about 12% MRSA. And the other thing is Pseudomonas we have had in about 3% of the patients, which is not too common in other major series. And in fact, in about 5.8%, we have had more than one organism. And in the patients two patients who died, they had at least 3 organisms which we could identify, and some of them were resistant to multiple drugs. And this is some surprising finding you can find. This is what happens when somebody keeps a gauze piece inside the pocket and forgets to take it out, and these patients come back with infection. So you can see the leftover gauze piece. And what I advise people not to do is not to put gauze pieces and leave it behind when they do an implant. So this is something I would say, don't do it. Don't put gauze pieces in the pocket. And you can see that this causes infection. And we had to remove multiple pieces of gauze in these patients. And once we do this, what we do is we do a temporary permanent pacemaker. We put a permanent pacemaker wire with a screw-in lead and deploy the active fixation lead in the RV and connect it to an explanted old pacemaker. And we also we do multiple blood cultures. The first blood cultures come in usually after a week of antibiotics when the patient has been afebrile for at least 72 hours. And we wait for a negative culture, after a negative culture for at least 72 hours. In the interim, we have this temporary permanent pacemaker, and we have now started mobilizing these patients back into the room to try to save time in the intensive care unit and thus reducing the cost. The mean time to device replacement has been about 11 to 15 days. So they require quite a lot of antibiotics before they are culture negative, because already most of these patients would have received multiple antibiotics. Now, I would like to conclude by saying a few things. It is not uncommon to have infection in India because there are multiple operators with low volumes implanting devices in India. Unfortunately, the referral for lead extraction in India is often delayed. And many of these patients have multiple hospital admissions and antibiotic therapy prior to referral, which adds to the morbidity and mortality probably. Many of these patients we would have probably missed because they would not have come back to us because of mortality. This also causes a lot of financial distress to the patient. So when they come to me, they hardly have any money left, because with what money they would have probably spent with multiple hospital admissions and antibiotic therapy, we would probably have been able to do the lead extraction very safely and reimplant a new device. There is the general lack of awareness of lead extraction in India, and this is probably the most common cause of delay or denial of this therapy in most of these patients. And I always say that early referral to an experienced center probably reduces the financial drain on the patient and also the morbidity and mortality. Thank you all for a patient hearing. And I would like to sort of close down by thanking all my fellows who have helped me in putting together all this, and all my patients who have been sort of helped me to, learn from them. Thank you all.
Thank you, Dr. JP. And with that, we will move on to our panel discussion. And I invite all the speakers to take active part in the discussion. So going through some of the questions that have already been raised by some of our participants, we have a question to Dr. Schaeffer, and this was from the first talk. Dr. Padmanabhan wanted to know what's the protocol for anticoagulation for lead-based masses. So Dr. Schaller, if you could just tell us.
Yeah, in general, we don't think that's an indication for anticoagulation. Most of these leads have things on them, so usually they're small little masses, little fibrinous materials that are clinically irrelevant and likely not likely to respond to anticoagulation. We haven't found any decrease in the prevalence of these thrombi in patients that are already on anticoagulation. So, but that being said, there probably are some patients where you see an extreme version of this, a large thrombus on a lead that is new, that I think it is reasonable to try anticoagulation. The question is, how long are you going to keep them on this for? It'll probably come back. And of course, there's other things to consider, such as PFOs and ASDs, and then it can become a little bit more dangerous if you think about if you think that there's a risk for cryptogenic stroke. So I think you have to use common sense, but in most patients with these masses that are not overwhelmingly big, I don't think there's a role for anticoagulation.
If you had a patient who also had a fever alongside, and there is a possibility that there could be an IE, how would you view mass attached to the lead? Are there any specifications that help you decide this is more likely to be a vegetation rather than a thrombus, or you don't really have any features to distinguish between the two?
Yeah, for people like me, that's like the holy grail. Are there characteristics of these masses that suggest vegetation versus thrombus? And the answer right now is no, other than there's a suggestion with some of our data and some of other people's data that the size maybe lends itself more to infection than non-infection, but there are the sensitivity and specificity of that is very poor. So it's very important to appreciate context and to not overreact just on the basis of a lead-related mass.
Dr. Gupta was asking about the role of CT venography prior to extractions. Do you routinely perform them, or do you just rely on eyes?
I think CT venography is pretty useless in these situations. In addition to surface ultrasound, it's very hard to get a sense of areas that are narrowed, let alone moving masses in the body. So I think there is a role, which we didn't discuss, for risk stratification of patients prior to lead extraction, looking for calcium, but not specifically the venography portion.
Called for extracting a lead with a large mobile vegetation. Do you have a certain size of a vegetation beyond which you would prefer to send the patient for surgery? If so, what's that size?
Yeah, so but usually that's a very rare situation. In fact, the question is, what are the characteristics of the thrombi that make it dangerous? There's been one patient, I actually think it was Dr. Dixit's patient, who had a thrombi on their lead that was very large, 2-3 centimeters, something like that, but it was chronic and it was circular. So it was almost like a big fibrous ball. And if you shear that off, there's no doubt that will cause hemodynamic compromise. Most of the masses we see are fresh thrombi, or when they're very big, they tend to be vegetations. And the characteristics of the vegetation are that they are friable, they're multilobulated, and they usually just embolize at various times during the procedure. And thus far, in my experience, I have not seen any hemodynamic problems. So one case over 8 years in a chronic thrombus, which we sent to surgery.
Dr. Bera was inquiring whether you routinely keep a guide wire and a balloon across your SVC for your extractions.
I think that's the standard of care. A wire is easy, cheap, and harmless to place, and you'll really regret not having that wire if you are trying to place it after a laceration has occurred. So Whether or not you utilize the balloon before or after is a different story. I think it's standard of care in 2020 to have a wire up the IJ in every lead extraction case.
And the other question from Dr. Gupta was, what was the incidence of pocket infection in patients with prolonged lead extraction procedure? This question is to Dr. Epstein. What's the incidence of pocket infection in patients with a prolonged lead extraction procedure with reimplantation being done at the same time?
Rob can speak to this also. Certainly if there's systemic infection, it's inadvisable to do same procedure reimplantation. On the other hand, if it's very localized pocket infection, there is a literature suggesting that that can be done. I personally tend to be very conservative and try to separate them, but for the financial constraints that were discussed, I think for a very localized pocket infection, that can be justified.
And Dr. Yadav wants to know about the value of a PET-CT in diagnosing infective endocarditis in terms of infection when you don't have vegetations.
Oh, gee. That's been floating in the literature for a long time. I personally have never used it, not been at an institution where it's been done. I think our threshold for worrying about, if you're thinking that somebody's infected, and especially if they have continued fevers, you just have to assume that the system is infected, and it would not prevent, and a negative PET-CT would not prevent me from probably removing a system.
But what about the other way around? If you had no evidence of an infection, but actually had a positive PET-CT suggesting?
Well, if it was an incidental finding, I wouldn't explant. If the PET was done for some other reason, sort of like the finding of incidental thrombi that we see on leads. Here at Penn, there's a very nice paper that was done by Greg Supple that showed 30% of people who undergo AF ablation, when ice is put up, they have thrombi on, or they have masses of some kind on defibrillator and pacemaker leads. And these are just incidental findings. They don't mean anything.
Another question to you, Andrew, is from Dr. Arora with regards to the usual antibiotics that you use for your implants. Is it cefazolin, vancomycin, and clindamycin, or do you have some other choices? Are these the usual antibiotics you use?
You don't use gentamicin. You mean for the...
No, clindamycin. Clindamycin.
Yeah, but you mean post-op?
I think she was referring to pre-op. Dr. Arora was referring to pre-op.
Yeah.
Well, I wanted to understand what is your pre-op and post-op protocol for usage of antibiotics in a fresh implant. And while we saw that case where there was a puckering and you were waiting and watching to see in case the infection is going to be there for the pocket, what antibiotics do you put the patient on?
Yeah, we use a cephalosporin pre-op, and if they're panallergic, vancomycin. We have not used Clinda as a perioperative procedure. Clinda is useful for if you are concerned about a superficial cellulitis, and that's a very standard antibiotic that's used in the post-operative setting in that first 7 days.
So, Dr. Epstein, do you routinely put antibiotics into your pockets at the time of implant?
Well, we use antibiotic flush, and we've been using the envelope for virtually all generator changes and prolonged procedures.
So you use the antibiotic flush plus the envelope nowadays?
Yes.
Okay.
Dr. JP wanted to say something actually.
Now I'll try to give the Indian perspective of what we do. Because we have restriction on finances, so we don't have ice in our lab. It adds to the cost for the patient and we can't use it. And many labs do not have facility to do eyes. Having said that, I still use CT because it gives me an idea of the way the lead has traveled and whether there's calcification there. Number two, when do we use PET? Many of our patients definitely have had received a lot of antibiotics before they come to us. And they would have had periods of fever with periods of being completely afebrile. And we are not sure, and we may not pick up the vegetations also on transesophageal echocardiography. And there's always a suspicion of infection in these patients. And our blood cultures may not be positive. So in such a case, probably for us, PET is useful to say that, okay, if it's a positive PET, I would still say, okay, there is an infection, I would go ahead and remove this whole system out. So that's where I would use my PET, but not for all cases. And regarding Dr. Schaller wanted to know about the drainage. Unfortunately, we do not have the bipolar cautery in our system, which you have it. So what we do is we try to use a regular cautery to get as clean a pocket as possible and to see that it doesn't bleed. We don't put in, all this, pack these pockets with gauze and leave it alone. So what we do is we carefully cauterize each and everything and wait for some time. And even after that, we put a drainage. We get it from the surgical ICU. We put a small drainage into the pocket from the dependent portion and connect it to an active suction so that it drains it out. It makes it so much more easy for us because we do not have the the luxury of having the bipolar cautery nor the ice. So we have to sort of do some amount of modifications of a procedure.
Dr. JP, I just wanted to know, with your experience in laser as well as the mechanical extraction devices, what is your final take? Do you think laser has a definite advantage over the mechanical extraction devices? My general impression with having used laser during my training was that laser significantly reduces the duration of the procedure. But that apart, I wasn't really sure whether it actually scores over the mechanical extraction devices. What is your opinion?
Well, there is nothing like I'm quite stuck to laser or quite stuck to, mechanical rotate, because when we go in for a device extraction, we should be able to swap one from the other. Many a times I swap from a laser when I find that there is a lot of fibrosis in calcium. I would, just like Dr. Schaller showed, you'll have to take out the laser sheath and then use the cutting mechanical tool. So there is nothing hard and fast. The advantage of laser is you probably need much lesser traction to keep the rail on, so that it makes it much more easier for us to traverse. And this is especially useful when you have leads like the thin line leads, which are very fragile, or you have leads which have been cut and where you cannot get the lead locking stylet all the way through, and you can't put in a lot of traction on these leads. So laser in that way probably gives us a little more leeway to just go ahead and do it with much lesser traction and get the leads out. But having said that, there are times when we have to swap. We have to be mentally ready to swap. We have to be mentally ready to go to the femoral to get the rail, because if we do not have a proper rail, your sheath is not going to track. And that is very, very important. And that point has been very well demonstrated by the lecture by Bob Schaller.
Dr. Epstein, we sometimes end up doing cases much longer than we expect to. For example, it may be doing a CRT implant and getting the LV lead in the right position takes much, much longer. Procedure drags on for sometimes 6 to 8 hours. And in such situations, I psychologically feel comfortable to give them oral antibiotics for about 7 days or 5 days after the procedure. But clearly from your talk, you felt that was not a advisable practice. Is that what you would go by? I mean, even if it was a long procedure?
Yeah, I think certainly for a long procedure to give a dose of postoperative antibiotics is reasonable. And the recommendation is to you doing it for 24 hours is fine, but there's no added benefit after 24 hours.
Thank you.
I don't think so. We have a clear-cut data from India, how to manage device patients and device infections. Because what I have learned from my experience that, it doesn't work here that we just give antibiotics for 24 hours. Whatever best we may do to have a proper sterilization and do a good procedure, a quick procedure, I need to give 48 hours IV antibiotics and 5 days oral antibiotics, and to have a good result. I mean, I would say this is the minimum that I have to do. Otherwise, there is always a risk of infection. There is always a risk of infection, even with the best of hands. What do you say, Dr. Saxena? What is your experience? This is my experience in my corporate hospital. So you have to unmute yourself.
I agree with you, Vanita. So in India, we have to use more antibiotics. That is true. But our practice is to use 48 hours intravenous antibiotics and then another 5 days oral antibiotic.
Yeah, same here. From the actually, I've learned it from you only. So, and my thinking hasn't changed for long, because the staff is the scariest organism, and hospital acquired staff gives me jitters, totally.
But I can tell you the one thing COVID pandemic has done is that the infection rate has really gone down. I mean, infection means that the wounds don't even look inflamed, and the counts don't go up on second or third day. So,
correct.
Because every staff member is very careful with washing hands and wearing masks all the time. So that has been, there has been certainly a change.
Some blessing in disguise.
Absolutely.
Well, I think on that positive note of COVID being a blessing in disguise, I think we should bring this session to its end, because I think we are 15 minutes over time, and I think this was really, really terrific. I have to admit that the data shared by Dr. Jayaprakash is very sobering, makes us realize that we are very fortunate with some of the things that we are able to do here in the United States, and we shouldn't take them for granted. And obviously congratulate all the work that people are doing with far less, but just equally great, accomplishment at the end of the procedure. So thank you for sharing that with us. And of course, I want to thank my colleagues, Dr. Schaller, Dr. Epstein, for taking time out from a Friday where they are going to go back to work, as am I, to spend time. And this was, I'm sure, greatly appreciated by the membership of IHRS. So thank you. I hope everyone has a great weekend, and let's stay with that positive note on COVID.
Great session.
Thank you.
Thank you.
Thank you.
Thank you, everyone, and be safe.
Before we close up, who do you think will win, Joe Biden or?
No politics, no politics, no politics. Can't get into that. We